Good evening, everyone. It's 8 p.m. UK time, so as always, it is time to start our live event tonight. It's good to be back again, and I hope you can hear me loud and clear. I am your host, Caroline, and welcome. And of course, I would like to introduce you to our new guest. And today with us, you can see her already, is Dr. Jana. Hi, Dr. Jana. How are you feeling today?
Hi, good evening, everyone. Very good. Thank you for having me.
Thank you so much for joining us and our initiative, Stronger Together. So, as always we will start with Dr. Yana's presentation. But before that, let me tell you a few things, of course, about our Stronger Together. So, as you know, those online events have been brought to you so that we can help you out throughout your struggle. And we are inviting top fertility experts so that they can help you with any questions that you might have, and also so that you can find out a bit more on various topics. We are focusing mostly on faith attempts, but of course, as you can see, there are plenty other topics that we definitely want to discuss and give you a chance to find out, to learn, but also so that you can ask your questions. And I just also want to mention that, as you know, we are also a winner of Best Marketing Initiative. We have received this award very, very recently. And well, I definitely want to thank our ambassadors and partners for their support, because we wouldn't be able to get that award without their assistance, without their help. And of course, as always, you can see them here. And I want to thank all of our IVF experts that have been here and will be here. Again, without their help, wouldn't be possible. But most of all, I would like to thank you for joining us over and over again to our live events. It's every day, so I know some of you have been here even every single day. So thanks for that. This is definitely we definitely appreciate it, and we definitely want to continue and give you as much um, knowledge out there as we can. Okay, and well, today definitely we have another topic to discuss. And as you can see, it's endometriosis and fertility. And today with us, it is Dr. Jana Bechthold. She is the gynecologist from Clinica Tambre. So hello once again, Dr. Jana. Thank you so much once again for joining us tonight. And as always, we will start with Dr. Jana's presentation. And after that, it will be time for your questions. All you need to do is just type in the questions in the chat section so that Dr. Jana can help you out. Okay, and well, I guess we can start with the presentation. Dr. Jana, are you ready?
Yeah, thank you very much for the
Excellent.
introduction.
Thank you so much. Let's go ahead.
So, let's talk a bit about endometriosis and fertility. That's our topic today. And yeah, what do we want to talk about? First of all, I want to explain what is endometriosis. How do we notice endometriosis? And what does that mean for your fertility? So does endometriosis affect the fertility? So then we want to talk about treatment options, and also treatment options regarding fertility. At the end, we have some conclusions. So let's start. Yeah, what is endometriosis? So we all know the endometrium, that is the inner lining of the uterus. And so endometriosis is when endometrial tissue is growing outside of the uterus. So it's growing on places where it doesn't belong. That can be outside of the uterus on the outer wall. It can grow on the ovaries, and there, for example, also result in some cysts. Also, it can be on the bladder, bowel, so just on spaces where it doesn't belong. The endometrium grows every month with our menstruation cycle. And results in the menstruation. So what happens to the endometriosis that is outside of the uterus? It also grows, and there it can cause, for example, pain or other things that I will explain later. More or less 10 till 15% of women in fertile age suffer from endometriosis. So it's quite common. The cause is still not scientifically 100% proven. So there are some theories how the endometrium gets there to these places. And also, why does some women suffer from it and other not? So probably there's also some genetic issue, or that it's also genetically, but it's not 100% proven. So there are just still a lot of investigation going on. It also seems that it has some immunologic and endocrine components. Also, the endometrium and the endometriosis has an impact, or the hormones of the menstrual cycle have an impact on the endometriosis. So, as I said, it grows under the influence of the hormones that we have in our natural cycle. So how do we notice endometriosis? Possible symptoms can be strong pain during menstruations. Also, it can occur strong and irregular menstrual bleeding, pain during sexual relations, and also sometimes changes in intestinal rhythm. So it can be obstipation, diarrhea, or something like that. It's very difficult because up to 50% of the women that suffer from endometriosis does not experience any symptoms. And on the other hand, not every woman that, for example, has strong pain during menstruations suffer from endometriosis. So it can be quite difficult to diagnose endometriosis. We can, if we suspect endometriosis, we can do an ultrasound. And sometimes, if they are really bigger foci or cysts, we can see that in the ultrasound. But if it's not cysts or really, bigger endometriosis, it's really hard to see it. So normally we maybe would not even see it in the ultrasound. The diagnosis is done through laparoscopy. So if we have a woman that suffers from a lot of pain and we suspect endometriosis, we should do a laparoscopy, and so we can see the endometriosis, and we can take a biopsy and verify if it is endometriosis that we are seeing. The problem is that many women suffer from endometriosis, and the diagnosis, they get it many years later. So it can be until even 5 or 7 years that a woman is suffering from endometriosis before it's diagnosed. So does endometriosis affect our fertility? Here also, it's up to 50% of the women with endometriosis that have fertility issues. So not every woman with endometriosis suffers from fertility issues. What can happen? It can be a blockage of the fallopian tubes, or like an inflammation. Also, we know that endometriosis can decrease the ovarian reserve and also the quality of the oocytes. There can be also changes in the menstrual cycle. So with that, it's also more difficult to getting pregnant. And we know that endometriosis can also there can also be a deterioration on the immune environment. And also it can have an impact of the embryonic implantation. So we see sometimes also poorer endometrial receptivity. I will explain some of that also later. So when we have endometriosis, what are our treatment options? I will talk about surgical and conservative options, and also options for fertility treatments. When it comes to endometriosis, it's not so easy to take the decision of a surgical or a conservative therapy. So the surgical removement can improve the fertility. So if we do a laparoscopy and like get rid of every endometriosis we see in the pelvic, it can improve the fertility, or normally it does. The problem we have is that the endometriosis often affects also the ovaries. So if we do an operation on the ovaries, we always take some healthy ovarian tissue, and that will worsen the ovarian reserve. So it will decrease the fertility. So it's a decision. The decision is not so easy to do a surgical treatment or not to do it. It depends on the severity of each case, how the endometriosis is treated. Also, if the patient has a lot of symptoms or is asymptomatic. The conservative treatment would be, for example, of course, pain therapy, so painkillers that we can use, and a suppression of the ovarian function by hormones. For example, in a lot of cases, we use a specific anti-baby pill without any pause. So we take it for several months without stopping. So with that, we can make a down regulation of the ovaries. So there would not be a menstruational cycle. And with that, it's not possible to heal the endometriosis, to get rid of it completely, but we can improve it, or we can just suppress it. So normally the patients wouldn't have many symptoms, and the endometriosis would not grow, would not get worse. When it comes to fertility options, we can do inseminations with patients that suffer from endometriosis. This would be an option for younger women with light endometriosis. We would do an IVF or ICSI with more pronounced endometriosis, and also if there are other factors that affects the fertility. Egg donation would be an option for women with greatly reduced ovarian reserves. So, for example, if there is almost not healthy ovarian or active ovarian tissue left, egg donation is a good option. And the results, regarding pregnancy rates, are just as good as for patients without endometriosis. Always speaking of egg donation. So here we don't see many differences between patients with endometriosis or without endometriosis in the egg donation. We know that the limiting factor is the ovarian reserve, always when it comes to fertility, and also of women that suffer from endometriosis. But also the implantation of the embryo can be impaired in patients with endometriosis. This can happen, for example, due to the chronic inflammation that some patients with endometriosis suffer of. And also there are changes in the endometrial lining microbiome possible. Also, we know that some patients with endometriosis can have a relative progesterone resistance. So that also would have an effect of the implantation rate of the embryo. How can we improve the endometrial receptivity? So we know that the ovarian reserve is really difficult. We cannot really improve it. The endometrial receptivity, yes, we have some options to improve it. So more or less 30% of all patients with or without endometriosis show alterations in the implantation window. So that means that the moment that the embryo is implanting in the endometrium is not really prepared. It can be pre or post receptive. So to know what is the optimus time for an implantation, we have there's a test. It's called ERA test. And it's part of the endometrial test. It's 3 tests: the ERA, ELLIS, and EMMA test. So the ERA test is to see if the endometrium is prepared for implantation, like the implantation window. In the same test, we can do a biopsy, and the test is called ELLIS test. And this lets us know if there's any endometritis infection in the endometrium. The third test is the EMMA test, and this tells us about the microbiome in the uterus, in the endometrium. So this is one test. It's like 3 tests, but they can be done at one time. So we would just take a little sample of the endometrium, and we can do all these 3 tests together. With it, we can eliminate problems with the endometrial lining and improve the receptivity of the endometrium. What we also recommend is to check the progesterone level before the embryo transfer. So in case that it's decreased, we can add some progesterone before doing the transfer. Do the pregnancy rates, the pregnancy, if you get pregnant with endometriosis, there's no higher risk during pregnancy. So once you got pregnant, there should not be any problems during pregnancy. Also, the symptoms, if you suffer from pain before getting pregnant, normally or usually during the pregnancy and also during the breastfeeding, there should not be the typical symptoms patients with endometriosis suffer from. Also, endometriosis recurrence is possible. So even if we do an operation and get rid of all the endometriosis implants, it is possible that it comes back. So we know that, for example, about 5 years later, maybe 15% of the patients would again suffer from endometriosis. So it's nothing that we can get rid of 100%. So what are our conclusions? Endometriosis is a common cause of infertility. We said like 10 till 20 or 15% of women at fertile age suffer from it. and more or less 50% of these women have fertility issues. Surgical therapy depends on the severity and also on the symptoms of the patients. Endometriosis can lead to fallopian tube conglutination. It can lead to low ovarian reserves and also poor endometrial receptivity. If you want to get pregnant and or you have fertility issues and suffer from severe endometriosis, IVF ICSI is the best option, the best treatment option. Egg donation would be an option where in women that have a very low ovarian reserve, and egg donation in patients with endometriosis have the same pregnancy rates, more or less, than as in patients without endometriosis. So at the moment, that's it. And I'm happy to hear all your questions.
And wonderful. Thank you so much, Dr. Jana, for your thorough presentation with lots of details. And thank you for explaining endometriosis to us. And well, now it is time to start our Q&A session. Dr. Jana, are you ready for the questions? There are some of
Yes,
those
of
ready.
course.
Okay, that's great to hear. And well, let's have a look at the very first question that we have received. Okay, it's a bit longer one, okay? And it's in two parts. Okay, so
Okay.
let me start with the first one. I am 33. I was diagnosed with endometriosis in July 2018 during laparoscopy. I took GnRH injections for 3 months. In January 2019, I started IVF. Ovum pickup and embryo transfer was done in February. 18 eggs retrieved, 12 blastocysts, day 3 embryos developed, 3 embryos transferred. After this, I had 3 more transfers using the frozen embryos and successful implantation. And the second part, during recent MRI and hysteroscopy, endometriosis is still seen. Recommendation by new doctor to start IVF once ovum pickup is done. Treatment for endometriosis advised for a period of 3-4 months. GnRH, Soladex, or equivalent to be used. After this treatment, the embryo transfer will be done. Only frozen embryos to be used. Is it advisable to take GnRH again? What other cure can be suggested for endometriosis? Thank you for your very first question.
Thank you very much for the question. So the question is if it's advisable to take GnRH again. It depends a bit if it's with what stage of endometriosis you have. But we know that the implantation of the embryo, it's decreased in patients with endometriosis. So we sometimes, yes, we use the GnRH to make like a down regulation of the ovaries. So we know that with that we can improve the implantation rates. So I think it would be recommendable to use it. And yeah, you have to use it 3 months, maybe 4 months. It's not necessary, but it can improve the cycle or the transfer if you use it for 3 months. What other cure can be suggested for endometriosis? There is not such a thing as cure. We can, of course, if you suffer, have a lot of symptoms, it's possible to do an operation. But if you want to get pregnant, as I said, it's also a risk. So we could remove too much ovary tissue. So normally we do not recommend surgery before getting pregnant. The only thing we can do is to give, for example, there are some birth control pills with a Gynecologist, or just also a progesterone called Gynecologist, like the mini pill. And you would take it just without any break. So you would not do the 21/7 cycle with the pill. You would just take it straight through. So with that, you can you will not cure the endometriosis, but you can get rid of the symptoms, and it would not get worse. Let's say it like that. It can decrease, but the normal thing is you won't get cured, but you can live with that, and many patients live good with that, taking that medication.
And excellent. Thank you so much for your very first question once again, and Dr. Jana for your advice. Okay, sorry, there is a follow-up from the very same patient, so let me go to this one straight away. Does GnRH injection have long-term side effects? I had taken the birth control pills during one cycle, but unfortunately the transfer didn't work.
Long-term side effects, if you take it like 3 months, it should not have long-term side effects. What GnRH more or less does is put you in a menopause status, so it just stops the ovarian function. So of course, if you would take GnRH a long time, of course, you would be in a premenopause that can have effects that we don't want in young women or women before menopause. But if you take it like 3 months, there shouldn't be any problem.
All right. Again, thank you for that and for your clarification to this. And of course, there is a thank you. Sorry for the long question. Thank you for your response and information. Well, we are
You're
definitely
welcome.
happy that it was useful for you. Excellent. Thank you so much. Okay, and let's have a look. Of course, there are plenty more questions coming up. And let's have a look at this one. Would the ERA Alice Emma test need to be done on potential surrogates as well?
Let me see if I understand the question right. I don't get I don't really get the question. Sorry. Maybe you could need to be done.
If you can
Surrogates.
clarify, that would be great, of course, as well, just so we can answer. It's okay. We can always go back to this question. Okay, please
Yeah,
just
it's
let us know exactly what you mean, and we will go back to this question. Okay. All right.
perfect.
Let's have a look. Okay, if you could just clarify this one. Is endometriosis the same as fibroids?
No, it's not the same. Fibroids are, let's call it little tumors. Tumors, it's not a bad thing. It's like benign, but it's not. This is more from the myometrium. So endometriosis is just, as I said, just the endometrium, so the inner tissue of the uterus. So it's not the same.
Okay, once again, thank you for the clarification to this one. And one more here. I have adenomyosis. Is there any treatment for that?
Endomyosis is a bit similar to endometriosis, but it's just inside the uterus, so inside the uterus wall. So the treatment would be very similar to endometriosis. So also like the birth control pill, or for example, if we do embryo transfer in patients with endomyosis, we do recommend do a down regulation for 3 months before having the transfer. But more or less, it's the same treatment.
Okay, understood. Again, thank you so much for that. And of course, there are more questions right here. And just let me go to the next one. Sorry, I'm just checking. Of course, someone is typing, so just need to check. Yeah, next question is right here. I have endometriosis in my ovaries, low AMH and thin endometrial lining, 3 millimeters, currently on estrogen course of 3 months. Is there anything I can do to improve my egg quality? I have just had an operation to remove my septate uterus and have a coil to keep my uterus in shape. Is IVF or ICSI my only option?
Unfortunately, we cannot. There's not much we can do to improve the egg quality. We know that patients with endometriosis sometimes suffer from poor egg quality. So it's important to have the endometriosis controlled. As I said, it's not necessary to do an operation, but try to avoid having regular cycles. So that with that, maybe we can improve a bit the egg quality. And yes, I think that IVF or ICSI would be the option. So if we're talking about low ovarian reserve, inseminations would not make any sense. Depends on how low the AMH would be. The option would be IVF, ICSI, or even if it's really low and we don't have almost any ovarian reserve, do an egg donation. But normally, yes, IVF or ICSI would be the option.
And thank you once again for your question and your answer to this one as well. Okay, and let me just have a look. Next question is also ready. Is it advisable to downregulate even though you use donor eggs, and if so, for how long? Also, one of my tubes is blocked due to endometriosis and is swollen. Should that be removed before embryo transfer? And to do the ERA Alice Emma test?
Yes, if your tube is blocked and swollen, so if it's filled with liquid, yes, we recommend do an operation before. So because if it's filled with liquid, this liquid can enter the uterus when the embryo wants to implant, and that can be kind of toxic for the embryo. So that in this case, the recommendation would be to have a surgery and remove the tubes. Or the one tube that is blocked and swollen. Down regulation, we do not recommend it for all patients with endometriosis. It depends a bit if it's really in what stage it is. So as I said, with adenomyosis, we would recommend do a down regulation before transfer. With a light endometriosis, it would not be necessary normally.
And wonderful again. Thank you so much for that. And there's another question from the very same patient. Would the percentage be lower for implantation if you have both endometriosis and adenomyosis, even if you use donor eggs?
What be the we know that the implantation can be lower if you have both or endometriosis or adenomyosis. So more important is the egg quality. We also know that the implantation can be affected, but as often in medicine, there are many studies, and it's not 100% clear. What a lot of studies could see that if you have endometriosis and or adenomyosis, if you use donor eggs, there was no significant difference in pregnancy rates. It doesn't seem to have such a great impact. So it seemed is it more important the egg quality. So the pregnancy rates are almost the same if you use donor eggs.
And thank you once again for that. At least at the moment, we need to wait a bit because someone is typing, so I need to wait for the question. So, of course, let me remind everyone that if you have any questions that and you would like to get some advice, just go ahead and type those questions in so that Dr. Jana can help you out. And we still need to wait a bit for the next question. And here it is. A question regarding fallopian tubes. Both my tubes are blocked because of adenomyosis. Is surgery essential for IVF success to prevent toxins to reach the embryo, as you said in last question? I shall undergo GnRH treatment. Will that be enough?
The GnRH treatment, that's a good idea. If there's a difference if just the tubes are blocked, so that would be there would be no surgery necessary. It would be necessary if the tube is filled with liquid. So that can be seen in a scan, in a ultrasound scan. So you just have to do surgery, or it's recommended if the tube is full of liquid. So if it's just blocked, there might be it might not be necessary.
Okay, again, thank you so much for your question. And again, someone is typing, so let's give it a second and see if we have another question. If not, we will be slowly finishing. So if you have any questions left, of course, now it will be time to type them in. And one more question is right here. Is there a special scan for this? The TVS, not sure, sorry, it didn't show this blockage.
Okay, and I I get what you see. I mean, you would see the liquid in a scan, in a transvaginal vaginal scan. So if the blockage is just when you check it, for example, if you don't see it in ultrasound, if it's just that nothing goes through the tube, it's no problem. You don't have to do any surgery. So this normally you see on a radiography. You see if the tubes are blocked or if they're free. So if the ultrasound was okay, there's no need to worry and no need to do any operation.
Excellent, thank you so much. And of course, there's a thank you from the patient as well. Okay, understood.
Yeah.
Thanks. All right, so there is one more. Okay, someone again is typing, so I just want to make sure whether it's like a thank you or another question, but we will be slowly finishing. And I just also want to add that, of course, if anyone would like to get in touch with Dr. Jana and her team at Clinica Tambre, of course, you can also use this link. I will send it just now, and there is an option to simply get in touch with Dr. Jana and of course the team. And I'm sure they will be more than happy to help you out and provide you even more details as well.
Of course, anytime.
Excellent. It's good to hear that. And yes, it seems that we will be finishing for today. So, everyone, thank you so much for joining us tonight for your questions. I believe this session has been useful for you. And as you can see, Dr. Jana, there are some things for you. Thank you so much for today. Appreciate all the info. Yes.
Um, I just wanted to add the other question that I didn't really get before.
Sure.
I think we are. I think the question was about the surrogacy.
Yeah.
So I personally, sorry for that. I don't have any experience with that because there's no legislation in Spain for that. So maybe that would be a good question. I don't know if there are any clinics specialized in that in UK or something. So maybe there would be someone more expert in that. Yeah, in that topic. So because here, unfortunately, it's there's no experience and no legislation.
Of course, and the surrogacy is not possible in Spain, of course. So, if anyone would like to get some more info, of course, there are some other options, other places like Ukraine for sure. I know that this is possible there, but of course, you can always send us the info. You can always send it to Caroline at ivfmedia.org, and that way, I'll be more than happy to also send you some more details, or even send it to some doctor that will be able to actually assist you. Okay.
Perfect.
And well, thank you so much for going back to this question. And of course, again, thank you everyone for joining us tonight. And Dr. Jana, it's been a pleasure to have you with us here today. And well, is there anything else you would like to add?
Thank you very much for listening and joining us tonight. So it's been a pleasure to talk to you about endometriosis. And yeah, I thank you very much. And I wish everyone a very good evening.
Thank you so much, of course. And I can only add that we are very happy to have you here tonight. So I definitely hope we can simply have another topic and discuss it on the next time during our next event. And once again, remember that this has been recorded, so you will be able to watch this. It will be uploaded on our YouTube channel tomorrow, but also on myivfenses.com. And as always, remember that if you go to Facebook, our Facebook page or Instagram, you will know about our upcoming events. We will be back here tomorrow. There is another topic that we will discuss. This time, repeated miscarriages. So I hope to see you there. And again, we will be here at 8 p.m. UK time. So thank you so much, everyone. Thank you, Dr. Jana. All of you,
Thank
wherever you
you.
are, have a lovely day or evening as well. And Dr. Jana, I hope to see you back here pretty much soon.
Of course. See you.
Thank you so much. Take care.
Bye.
Good
Thank
night.
you. Good night.